Hi, my name is Atif Darwish, Professor of OBGYN at University Egypt. The topic of poor ovarian reserve is very important and very controversial topic in modern practice because of the controversy regarding its definition and how to diagnose ovarian reserve and what's the impact of poor ovarian reserve on the ovarian response to the induction of ovulation in the context of assisted reproductive techniques, and actually it is an updated lecture on this topic. It is due to decreased or diminished ovarian reserve. Now the ovarian reserve is the quantity and quality of primordial follicle pool inside the ovary. You know that the follicle goes into different stages of development until reaching the mature follicle, which ruptures and forming corpus luteum later on. The primordial follicles are concentrated in the ovary, and they will change into primary follicles, secondary follicles, antral follicles, early, mid, and late antral follicles, and lastly pre-ovulatory follicle. Usually at birth, the primordial follicle pool is around 2 million primordial follicles, and at menopause it is around 1,000 follicles. So along the life of the female, she loses most of these follicles every month. You know, there is a cohort of follicles every month, around 1,000 follicles every month. The American College of Obstetricians and Gynecologists mentions that at 20 weeks in the intrauterine life, the females usually have between 6 to 7 million oocytes, but at birth this number declines due to continuous atresia and reaches 1 to 2 million oocytes. At puberty it becomes around 400,000. At menopause it is around 400 only. At the age of 37 it is around 25,000, and after menopause, as I told you, it is around 400, maximally 1,000 oocytes. But the ovarian reserve is not only the number of the primordial follicular pool inside the ovary. The quality of this primordial follicle and follicles inside the ovary is very important. So the ovarian reserve is a combination of good quantity and good quality of the oocytes, which means that some females have some problems in the DNA makeup of the oocytes, and this may lead to bad quality oocytes despite the good number of these oocytes. So poor ovarian reserve is both quality and quantity decline in the ovarian primordial follicular pool in women in the reproductive age group. Actually, it is a complex clinical phenomenon influenced by different factors. The most important and most significant and most independent factor is age. Other factors include genetics and environmental variables. The ISHRI consensus on the definition of poor response at Bologna mentioned some criteria, and these criteria are famous by the name Bologna criteria, which included 3 criteria for definition of poor response. They mentioned number 1, advanced maternal age. As I told you, the age is the most important factor to determine the aging of the ovary and the ovarian reserve. If the patient has an advanced maternal age more than 40 years or any other risk factors for poor ovarian response, this means that this patient is liable to be poor responder. But they mentioned we have to have at least 2 of these criteria. The second criterion is a previous poor ovarian response, which means less than 3 oocytes with a conventional stimulation protocol in a previous trial of IVF-XC or abnormal ovarian reserve testing like antral follicle count less than 5 to 7 follicles or decreased antimullary hormone less than 0.7 nanogram per milli. So if the patient has two of these criteria, age, one of the ovarian reserve testing, antral follicle count or antimullary hormone decrease, or a previous history of poor ovarian response, if she has two of these criteria, she is a poor responder. What you notice from this definition mentioned by the Ishri in this Polonia criteria, you notice some heterogeneity of the definition. You do not know which patient is considered a poor responder, what is the most important factor, age or other factors like history or abnormal testing. It is not clear. So the Ishri consensus definition, which is called Bologna criteria, is a little bit ambiguous. And there is overlap between the age, abnormal testing, and other factors. And as it mentioned in many publications, there is heterogeneity among poor ovarian responders according to Polonia criteria that resulting in divergent cumulative live birth rate, as mentioned in many studies. That's why another group developed another criteria which is called Poseidon criteria, which is acronym of patient-oriented strategies encompassing individualized oocyte number, which means that we have to classify patients into different groups. We cannot mention that we take two of the three criteria of the Polonia and this is a case of poor responder. You have to classify the patients into four groups according to Poseidon criteria. Group 1 and 3 are young patients. Group 2 and 4 are old patients. The group 1 and 2 are poor responders unexpectedly, which means that you induce ovulation, they have adequate ovarian reserve by ultrasonography or biochemically by antimullary hormone, and no problem, you started induction ovulation as usual in this age group, and you are confronted with a case of poor response, no ovulation, or no optimal response in this case. So group 1 and 2 are young and old patients with unexpected poor or suboptimal response, but group 3 and 4 are known from the start they are poor responder by their age or by the other factors like decline of the antral follicle count or antimullary hormone. So the grouping is very important to differentiate patients. This is very important for studies, for conclusions, for recommendation of some therapeutic lines. We have to divide our patients into four groups. Group 1 and 3 are young age group. Group 2 and 4 are old, more than 35. Group 1 and 2 are unexpectedly have poor or suboptimal response on the regular induction of ovulation, while group 3 and 4 are known from the beginning they are poor responders. Group 1 and 3 are important because they are young age, so they are less liable to develop embryonic aneuploidy after fertilization of this oocyte. While group 2 and 4 are old age, they are liable to have aneuploidy risk in the coming embryo. So group 1 is young age less than 35, antral follicle count is normal, more than 5, antimullary hormone normal, more than 1.3 or 1.2 nanogram per milli, and they are classified into subgroup 1A and 1B, less than 4 and between 4 and 9 antral follicle counts. Group 3 are young age again, but poor responders, antral follicle count less than 5, anti-malarial hormone more than 1.2. Group 2 is more than 35 but good parameters like intrafollicular count and anti-malarial hormone, while group 4 is known to be poor responder or poor reserve by decreased intrafollicular count and increased anti-malarial hormone in addition to the age after more than 35. So we have 4 homogeneous grouping of our patients, and this grouping leads to good understanding of the different subgroups, good development of individual treatment regimens, and research designs are more homogeneous and more informative. In the group 1 and 2, I told you the unexpected poor ovarian response, while group 3 and 4 are known to be have poor ovarian reserve. Now, what's the prevalence of poor ovarian reserve is variable in different studies between 10 to 24 or 25% of cases. What is the possible mechanism? Of course, maybe genetic background, as there are some gene problems in the FSH receptors, decreased number of FSH receptors in granulosa cells, defective signal transduction after FSH receptor binding, inappropriate local vascular network, increased vascular growth factor, abnormality in IGF-1 and IGF-2 levels, decreased secretory gonadotrophin surge, attenuating factor bioactivity. All these are possible mechanisms of why the patient has a poor ovarian reserve. Now we have a patient diagnosed by any criteria to be poor ovarian reserve, and we are now counseling this patient. She says or asks, what is the significance of being a poor ovarian reserve patient? We have to answer her clearly that the pregnancy rate remains low for your group, and this is despite a plethora of interventions and different lines of treatment. And again, if you got pregnant, you may have a high pregnancy loss rate, and you have to detect the premature ovarian failure or poor ovarian reserve as early as possible to make active intervention. Otherwise, the patient will lose her eggs, and she is obliged to use egg donation, which is not allowed in many societies. Now, what's the cause of decreased ovarian reserve? Maybe exposure to chemotherapy, radiotherapy, genetic abnormality, some genetic diseases, smoking, previous ovarian surgery, uterine artery embolization and ligation, autoimmune diseases, galactosemia, mumps, salpingectomy because it disturbs blood flow to the ovary, environmental factors, FSH receptor polymorphism, or maybe unexplained, which is called idiopathic. And this is very important. Now, what is the testing procedure to diagnose that this patient has a poor ovarian reserve? As we mentioned in the Poseidon criteria, that we rely on intrafollicular count and anti-malarial hormone, and some other tests can be used for detection or for estimation of the ovarian reserve. The ideal ovarian reserve test should be convenient, reproducible, cheap, displays little if any intra or inter-cycle variability, and demonstrates high specificity to minimize the risk of wrong diagnosis. And unfortunately, there is no perfect ovarian reserve test so far. If we look to this algorithm, we will see that ovarian reserve testing can be biological, which is chronologic age, and this is the most important issue. In the Bologna criteria, it's mentioned that less than 40 or more than 40. In Poseidon criteria, less than 35 or more than 35-year-old. It may be biochemical, static, like FSH estimation, basal FSH day 2 or day 3, FSH-LH ratio, inhibin B, estradiol or anti-malarial hormone, or maybe dynamic like clomiphene citrate challenge test and other tests. maybe biophysical, using ultrasonography to measure or to count the antral follicles, which is called antral follicle counting, ovarian volume or blood flow to the ovary. Or histologic, if you take a biopsy from the ovary and prove to have no follicles, this is called histologic diagnosis. So this algorithm shows different forms of ovarian reserve testing. The problem is that many doctors in practice rely on anti-Mullerian hormone alone. If you look to this algorithm, you'll find different tests. Why to ignore the age? Why to ignore the antral follicle count? Why to ignore ovarian volume or ovarian biopsy if you are doing laparoscopy and so on? Don't rely on one test. This is a misdiagnosis actually, and you have not to inform your patients that you have poor ovarian reserve based on just a static biochemical test, which is anti-Mullerian hormone, and you don't have idea and you ignore other tests. And this algorithm is very essential to put in your mind that we have different forms and different tools to diagnose ovarian reserve. So we have anti-Mullerian hormone inhibin B, follicle FSH, and estradiol. All these issues, if the patient has poor ovarian reserves, estradiol decreases, the FSH increases, inhibin B decreases, and anti-Mullerian hormone decreases. So the only static biochemical test which increases in poor ovarian reserve is FSH. Other tests are showed in this figure to decline. We will start by the famous anti-Mullerian hormone because it is frequently requested by all gynecologists all over the world. And I surprised that many doctors ask for or request anti-Mullerian hormones for estimation for some patients who are too young ovulatory with regular cycles. It is of no value for those cases. It is not a routine test for the females. We have to select the patient for anti-Mullerian hormone detection. The anti-Mullerian hormone is a very important hormone formed by the granulosa cell, and this hormone is secreted from the pre-antral and early antral follicles, and this hormone is considered as the earliest marker to show ovarian reserve decline. It is controlled by a gene located on chromosome number 19. So it means if you detect or measure anti-Mullerian hormone in the circulation, this means the magnitude of folliculogenesis in the early stages. The early follicular recruitment process leads to formation of secretion of anti-Mullerian hormone from the granulosa cells. So if you measure anti-Mullerian hormone at any time and you see it in the normal range, this means that the anti-Mullerian hormone secretion is okay, and the process of folliculogenesis, at least the early folliculogenesis, is good. So in the follicular phase of the menstrual cycle, it is secreted in good amount until the follicle reaches a diameter of 8 millimeter. After this size, the growth of the follicle into mature or antral follicle is taken over by FSH. So the early stages of folliculogenesis is controlled by anti-Mullerian hormone. The late stages until antral formation is controlled by FSH. So anti-Mullerian hormone and FSH are complementary for the growth of the primordial follicle into antral follicle. This is essential to understand. So anti-Mullerian hormone is a glycoprotein, and it is a marker of early pre-antral follicle development. And what is the proof that it is responsible for this growth from the primordial follicle to pre-antral follicle? the proof that some patients with polycystic ovaries usually have high level of anti-Mullerian hormone. Why? Because they have attempts to make folliculogenesis but usually fail due to polycystic ovarian changes. So this patient has multiple cysts as diagnosed by ultrasonography as recommended nowadays by the ISHRI SRM recommendation to be 20 cysts per ovary, and these cysts secrete anti-Mullerian hormone. So anti-Mullerian hormone will be high in the patients with polycystic ovarian morphology. It is a good marker for ovarian reserve. As you see in this figure, the anti-Mullerian hormone increases in the early stages of folliculogenesis from primordial follicle, primary and secondary follicles, early antral follicles, and mid-antral follicle. And after the follicle reaches 8 millimeter, there is increase of FSH level, which controls the process of completion of the process of folliculogenesis until pre-antral follicle stage. So the proof that the anti-Mullerian hormone is correlated with the number of the growing follicle is shown in this slide. It increases in cases with ovarian tumor. Some ovarian tumors, there is increased anti-Mullerian hormone, and as I told you, polycystic ovarian disease. It decreases or reaches in undetectable level in postmenopausal women and women with Turner syndrome. We have to announce that anti-Mullerian hormone is also called anti-Mullerian substance. It is formed in the intrauterine life, and it is produced by ovarian granulosa cell in the female and from the Sertoli cell of the testes in males. And it is very important in the embryogenesis in the intrauterine life of any individual, whether male or female, So in the male, it is produced from Sertoli cells of cysts, and it is responsible for suppression of Mullerian hormone, and it is produced from the ovarian granulosa cell in the females, and it works after puberty. So the anti-Mullerian hormone, as I already mentioned, is formed by the granulosa cell until the follicle reaches the size of 8 millimeter. And if increased level of anti-Mullerian hormone, the normal is 0.7 to 1.2 or 1.3 nanogram per milli. If it is increased, this may signify polycystic ovarian syndrome or some ovarian tumors. It is considered a good biochemical test because of the following issues. It is measured at any time. Not important to measure it during menstruation, premenstrual, postmenstrual, so it is very good advantage for the anti-Mullerian hormone. Untimed sampling, age-specific values, it is very important to be linked to the age, as we already seen it reaches to undetectable level in the menopause and postmenopause. It is available to be done by automated machines and potential standardization of anti-Mullerian hormone. So it is preferred but not optimal biomarker for the evaluation of ovarian reserve in women. Again, it is just one test. It is not the all tests for ovarian reserve. The main source of anti-Mullerian hormone, inhibin B, activin A, and 17 beta estradiol, is the granulosa cell lining of the ovarian follicle. After 8 millimeter size of the folliculogenesis, the FSH dependent inhibin B starts to complete the growth of the follicle until reaches to the dominant and the mature follicle. And the dominant follicle and mature follicle and growing follicles start to secrete estradiol. So if you measure estradiol and it is of normal level or good level, This means that the process of folliculogenesis is going well. If you measure inhibin B and it is of good level, this means that the process of folliculogenesis is okay. If the FSH is normal, this means that the process of folliculogenesis is good. And the same applies for anti-Mullerian hormone. So these hormones are controlling the process of folliculogenesis, starting from the primordial follicle until the mature follicle, and any decline of these hormones except estradiol means that the process of folliculogenesis except FSH, I'm sorry, this means that the process of folliculogenesis is affected. And if FSH is increasing, and particularly in the early stages of folliculogenesis, this means that there is poor folliculogenesis. So these biochemical markers are indirect indicators of the process of folliculogenesis. So if we have low anti-Mullerian hormone with high FSH, this means low ovarian reserve. Inhibin B, which means both it's secreted from granulosa cell of the primary, secondary, and early antral follicle, and represents the size of GnRH reactive antral follicles as shown in this figure. Inhibin B is decreased in second half in the contrast of inhibin A, which increases in second half of cycle. So if we detect decreased levels of serum inhibin B less than 45 picogram per milli, this means that the patient has poor ovarian response or reserve. Estradiol increased after the process of formation of antral folliculogenesis more than 8 millimeter until reaching pre-ovulatory. So if we detect low estradiol level, this means defective folliculogenesis. The estimation of estradiol is essential, particularly for cycles for assisted reproduction, and usually we measure it at day 3, 5, 8, and at the day of injection of HCG. On day 3, if you find a good level of estradiol, this means that the process of folliculogenesis is going well in this patient. If the level is 30 to 50 picogram per milli in the day 3, this means a good case and possible to have a good clinical pregnancy rate. Also, if it is low, it can guide us to detect the duration and the amount and dose of gonadotrophins used for induction for this lady. At day 5, we can repeat the test, and day 8, and if you find at day 5 the level is more than 300 picogram per milli, this means that the patient is fast responder and she is liable to have ovarian hyperstimulation. If she has at day 8 less than 300 picograms, this means that she is non-responder, and if less than 300 picogram by day 5 but more than 300 picogram by day 8, this means that she has a slow response for induction protocol, and we have to modify the protocol and dose. And again, at the day of HCG, we have to measure the estradiol because it is essential. If you find it more than 1,500 picogram per milli, this means that the patient is liable to ovarian hyperstimulation, and sometimes you cancel the cycle and make freeze-all technique for those cases. If it is less than 800 picogram, this means that she is low responder. If it is between 800 and 1,500 picogram per milli, this means that she is medium. Importantly, to measure FSH level, but please be cautious that if you request FSH, it should be in the beginning of the menstrual cycle, the beginning of folliculogenesis. The optimal is day 2 or day 3, because at this time the FSH level is normally decreased. But if you request FSH on day 8 or day 9, this is not good, because at that time physiologically FSH increases to increase the level of inhibin B. So FSH on day 2 or 3, usually it is less than 10 milli international unit per milli. If it is between 10 to 15, this is borderline or poor ovarian responder. But if it is more than 15, this patient has ovarian failure. In this figure, you see that physiologically FSH and LH increase in the mid-antral follicular phases when the follicle size reaches around 8 millimeter and continues to increase until the time of ovulation. And you know that there is LH surge and FSH surge at the time of ovulation. Biophysically, we rely on ultrasonography, usually transvaginal sonography. We measure two issues, which is ovarian volume. Normal ovarian volume is around 5 to 7 cubic centimeters. If it is less than 3 cubic centimeters, this means that decreased ovarian volume, and usually it is a predictor that this patient has poor ovarian reserve. As a reminder, if the ovarian volume is more than 10 cubic centimeters, this means that this patient is mostly having polycystic ovarian morphology. The second sonographic issue is a very important issue and one of the significant issues to diagnose ovarian reserve, which is antral follicle counting. Usually the antral follicle count is more than 5 to 7 follicles per ovary, and if it is less than 4 follicles in the early stages of folliculogenesis, this means that this patient has decreased antral follicle count, and a meta-analysis showed that those women are more likely to have cancelled cycles and less likely to get pregnant than women with more than 4 follicles per the ovary. For the investigations and research, Doppler ultrasound can be used to estimate the decreased ovarian stromal blood flow in cases with poor ovarian reserve. And this figure shows that the antral follicle count increases with time with the process of folliculogenesis from the mid-antral to the pre-ovulatory follicle. Also, decreased ovarian stromal blood flow by Doppler ultrasonography. Some tests also are used, which are clomiphene rate challenge tests with measurement of FSH and estradiol on day 3 and day 10 after giving clomiphene rate 2 tablets daily from day 5 to day 9. Exogenous FSH ovarian reserve test or GnRH agonist stimulation test. All these tests are a little bit complicated, inconclusive, and not widely used in clinical practice. Now we have a plethora of testing. What's the best test? As I told you, there is no best test, there is no optimal test, there is no ideal test. We have to realize that anti-mullerian hormone is important, as it can be measured at any time except when the patient is pregnant or using hormonal based medications. Antral follicle count is ideally measured at or counted at day 2 to day 4, estradiol day 3, 5, 8, and the day of HCG. FSH, as I told you, day 2 to 3 baseline. These are the best timing for requesting the estradiol, FSH, and anti-mullerian as biochemical, and antral follicle count as a biophysical test. Since there is no optimal or ideal test, we have to use more than one test, and this is a good message to all doctors. Don't rely on one test, particularly anti-mullerian hormone. Don't tell your patients that you have poor response based on one test, which is anti-mullerian hormone. You have to make combination, and these combinations give you a good idea about the ovarian reserve of your patient. If you have anti-mullerian hormone more than 1 nanogram per milli, antral follicle count more than 8 per ovary, FSH less than 10 milli international unit per milli, this is a good responder patient. So don't rely on one of these issues. You have to make these tests together to have a good idea about your patient. If the results are poor when you have FSH more than 12, intrafollicular count less than 4, anti-mullerian hormone less than 0.3, this is a poor responder. You have to tell your patient, I performed for you 2 biochemical tests, which are anti-mullerian hormone and FSH, and 1 biochemical test, which is intrafollicular count. It's better to add ovarian volume if it is less than 3 or 4. So by this biophysical and biochemical testing, I can conclude that you are having a poor ovarian reserve. Otherwise, you cannot tell your patient based on one test you have a poor reserve. This is very essential. But anti-mullerian hormone has been shown to be a better predictor than FSH of ovarian response to stimulation. If you are starting to give the patient ovarian stimulation for IVF, it is better to rely on anti-mullerian hormone as a predictor of success of stimulation. But it is generally found to be poorly predictive of pregnancy rate, especially in young patients. Both intrafollicular count and anti-mullerian hormone have good predictive value and are superior to day 3 FSH. But we have to realize that you don't have to be 100% sure that this patient has poor ovarian reserve based on one test, because this study found that approximately 20% of women who have discordant values, which mean normal anti-mullerian hormone and elevated FSH, or low anti-mullerian hormone and normal FSH, they have good ovarian reserve and good ovarian response, and this is called discordant ovarian reserve testing. So please don't rely on one test. Again, a combination is much more better than single test. Big study, which is a retrospective study on around 45,000 fish autologous oocyte cycles, detected live birth rate, and this live birth rate per cycle was high if we have a patient with normal FSH and anti-mullerian hormone, little bit less if the patient has high FSH and normal anti-mullerian hormone. So anti-mullerian hormone normal is good predictor of live birth rate, but the level or the percentage of live birth rate declines if you rely on high FSH and low anti-mullerian hormone in 19% and normal FSH and low anti-mullerian hormone in 26%. So low anti-mullerian hormone continues to be a better predictor than high FSH on live birth rate when stratified by age, and is in predicting cycle cancellation as well. Also, if we combine antral follicle count and baseline FSH in a big sample size study on around 10,000 cycles among around 8,000 patients, the diminished ovarian reserve as measured by means of baseline FSH and intrafollicular count is not associated with pregnancy loss in young in vitro fertilization patients. So this decreased FSH, increased FSH and decreased intrafollicular count is not associated with or not correlated with pregnancy loss in those cases. So please rely on more than one issue to estimate the ovarian reserve, and don't forget the algorithm of different testing of biophysical, biochemical and biological testing, and don't forget the age of the patient, the history, and so on. In conclusion, we have to mention that poor ovarian reserve is a major challenge in infertility cases, particularly in assisted reproduction. There is no single test ideal for diagnosis of poor ovarian reserve. We have to request more than test biochemical, biophysical, and biological testing for this patient. Sometimes histological testing when you are doing laparoscopy for any indication. Don't hesitate to take a small ovarian biopsy for this case. And one of the important updated issues in this field, which are useful tools for assessing and increasing the probability of having one euploid blastocyst, is to rely on new issues in the estimation of ovarian reserve. The first issue is follicle to oocyte index, which means the percentage of the retrieved oocyte compared to the number of follicles at the beginning of stimulation. So if you start stimulation with around 10 follicles, and then the number of retrieved by egg retrieval is 2, so the number is the percentage, or the index is 2 over 10, so it is 20%. If the follicle to oocyte index is 50% or less, this means that the patient has low follicle to oocyte index, which means that in the subsequent cycles you have to modify induction protocols, you have to modify trigger methods and improve the success rate. And this is a study mentioned as drained by or guided by Poseidon criteria. And this is the picture of low follicle oocyte index, less than 50%, necessitates more studies and changing protocols. And the low follicle oocyte index may be attributed to a problem in the induction dose, a problem in triggering, this is iatrogenic, and maybe asynchronization of the follicles, particularly in cases with GnRH antagonist protocol, or genetic or environmental factors. Another recently introduced issue in this era, which is ART calculator, which is a computer program, and you enter some data about the patient, like a patient's age, type of sperms collected from ejaculate sperm, from testicular biopsy, and so on, and you calculate the pre-treatment calculations to estimate number of possible number or probable number of premature or mature oocytes, and post-treatment, post-induction, to estimate the actual number of collected mature oocytes to achieve at least one euploid. So this is an example of how to introduce data to this calculator on the internet. You introduce the female age, the sperm source, ejaculate, epididymis, testicular, and the success probability is estimated, and you continue introduction of data, and you will have a probability, the possible number of mature oocytes. This is a pre-treatment. Post-treatment, you can estimate the number of mature oocytes retrieved from this patient and calculate the probability to achieve at least one euploid blastocyst after introduction of the pre-treatment and post-treatment data. It's important to recognize that this computer program relies mainly on the patient's age, which is an important factor for estimation of the ovarian reserve, and this issue is not present in the Ishri criteria, Polonia Ishri criteria, and actually it is present in the Poseidon criteria, because they classified the patients into 4 groups according to the age, less than 35 or more than 35, while Polonia relied on only 40 or more. This signified poor response, but this calculator can calculate to you the number of mature oocytes and probability to have, in a percentage probability, to have at least one euploid blastocyst after induction. The last conclusion of this lecture is that the Poseidon criteria for definition or grouping of the poor ovarian reserve patients is advantageous over the Bologna Ishri criteria, because it is based on the patient's age, the ovarian reserve markers, ovarian reserve response to induction of ovulation, and classified patients into unexpected poor ovarian reserve or expected poor ovarian reserve, and each subgroup is classified into less than 35 or more than 35. So we have 4 homogeneous groups, which leads to a better understanding of the different subgroups of poor ovarian reserve, better development of individualized treatment regimens, and better research design. And thank you very much. If you like this lecture, don't hesitate to press on like icon, and don't forget to press on notification and subscribe icons to have more lectures. And you can contact me directly on the email address atif_darush@yahoo.com. See you again, and bye bye.